Thank you very much for inviting me today, and thank you for the team from Gush, and thank you for meeting so many friends and collaboration. And Paolo, it just showed that how you set up this computer with me, this is called collaboration, and it's doesn't happen all the time with surgeons. So my topic is about patient-centered collaborative care. It's an important topic because we're here. We're here because we're collaborating. Now, this is the University of British Columbia where I work. And you can see how beautiful the campus is. It's just by a cliff. And the medical school is just close to the water. And in fact, there's a nude beach about 5 kilometers away. So that's why people choose the University of British Columbia.
So you watch people walking as they go.
Yes, that's right. We watch a gait analysis. And another thing that I love with British Columbia is a sense of health. We have Stanley Park within the city, which is one of the largest parks in the world. I think Central Park may match that as well, but I don't know if Central Park has such a beautiful setting. So today I'd like to talk about description of the importance of patient-centered collaborative care. What is it, and how can we use this approach to enhance our therapeutic alliance with surgeons, and also to treat the patient and enhance their delivery of care? I want to make you aware of the barriers that can affect the delivery of collaborative care. I want to discuss the practical strategies that we can have to enhance the physiatry surgical care, and I will describe some novel collaborative clinics and approaches that we have in British Columbia that I think we can learn from these models to enhance our clinics wherever we are in the world. So when we look at the collaborative care, what does that mean? The Canadian Medical Association in 2007 brought a very nice paper showing that it entails that physicians use complementary skills, knowledge, and competencies to provide care to a common group of patients. So in our group of patients will be patients with spasticity or neuro-orthopedic conditions. It has to be based on trust, respect, and an understanding of each other's skills and knowledge. It has to be mutually agreed upon division. So what do we do in the clinic, and how do we work together? And the relationship must be beneficial to the patient, but also important to the physician and other providers and caregivers. So what are the principles that we need to understand? So we have to look at that collaborative care has the potential to improve access to care, enhance the quality of life of the patient, enhance coordination and efficiency of care, and also enhance provider morale and decreases burnout. Because sometimes when we work in solo, we can be so hardworking, and we can also feel that the system is not helping us. So collaboration itself is superb. So when we look at the members of a collaborative team, we have responsibilities, almost a mandate, so that it can actually work proficiently. So we have to collaborate. We have to maintain a patient-centered focus of care. We have to understand and respect the roles and skills of providers within the team. We have to listen to and value the input of each team member, and also communicate effectively with all team members, and also the patient. Now, this is where the confusion happens in literature and research, in that the terms multidisciplinary, interdisciplinary, and transdisciplinary are mixed together, and then we cannot compare some of the articles and papers. So I want to describe very briefly how they differentiate. So multidisciplinary is, for example, a surgeon and a physiatrist working together independently and focused on specialty-specific goals. There's limited interaction between the disciplines. In interdisciplinary, the surgeon and physiatrist work together to achieve a common goal within the same setup usually, and there's more interaction and communication between specialties. This is where most of us are doing our clinics, is interdisciplinary. Now, where we're now morphing in this neuro-orthopedic world is this transdisciplinary. We all are working together. We're forgetting about boundaries. And Alberto Marianne showed a very nice descriptor of how you've been able to do a transdisciplinary team. It's also having the same template and also having the value of listening to the patient, caregiver, and the team members. Now, what are the barriers of implementing a collaborative care approach? Well, lack of infrastructure. You can have a great team, you can have great mutual collaboration between physician and surgeon and the physios and OTs, but if you don't have space to work in, it won't work. You need to have secretarial support. You have to have effective documentation, otherwise we will lose data of the patient, and funding is crucial. Also, issues with setup, efficiency, and flow. I'm a big believer if we don't think about setup, efficiency, flow, even if we have the best tenotomy procedures, the best ability to care for the patient, we will not be able to deliver the optimum care. Lack of time. We are all busy clinicians. How do we make more time? A very good idea is to have a more transdisciplinary team approach. And now I will talk to you about an issue which I think is very interesting, is territoriality between surgeons and physiatrists or healthcare professionals. As you know, it does exist. And Edward Hall, a prominent anthropologist in the US in 1963, designed this concept of proxemics, which means barriers in social interaction within the human body. Animals and humans have inherent space that they do not want to be encroached. So for example, in a human being, in his study, it shows that an intimate area is 0.5 meters from your torso. A personal area is 1.2, and a social area is 3 meters. So when we look at this encroachment, it also works within healthcare disciplines, that there are some studies between pharmacists and physicians that they encroaching the barriers, nurse practitioners encroaching the barriers of the physician, and physiatrists encroaching the barriers of the surgeon. So I like this little quote by Edward Hall, that each organism, no matter how simple or complex, has around it a sacred bubble of space, a bit of mobile territoriality which only a few other organisms are allowed to penetrate, and then only for short periods of time. These are our bubbles. The physiatrist I put as a small bubble, and the surgeon as a big bubble, and this is a traditional view. Now I could switch it the other way, the physiatrist could be the bigger bubble and the surgeon the smaller bubble. Now we need to pop these bubbles, and that's what we're doing today, so I congratulate each and every one of you for doing that. But how do we actually do this, especially for clinics that are starting off or designing more efficient care? So how do we minimize territoriality? So we have to break the barriers. It is not a power game. Space has to be shared. Patient focus is a key. Mutual respect is important. And finding the right team player is essential. Every one of the team members I've seen in your teams, you all have the camaraderie. We all have drinks after, which is amazing. You know, this is one of the, I'm not saying that you have to hire someone who drinks, but the point is socially, can you actually interact with them socially? That is an important point for collaboration. The other thing that's important is training our surgical residents, so the up-and-coming future physicians and surgeons, to collaborate. They should be teaching and doing teaching courses together at an early stage. So we should invite the physiatry resident to an orthopedic clinic and vice versa. And also we have to set realistic goals. If the surgeon wants to do something, the physiatrist wants to do something else, we stop right there and we discuss before treating the patient. I'm a big believer in the goal attainment scale. I'm also a big believer, and we all are, of caregiver burden. We have to include the caregiver as well in this picture. We have to look at health team goals, patient goals, and caregiver goals, because it's very important if we're doing research in the future, looking at efficiency of care. So ideally, I would say that why do we want to do collaborative care? We want to optimize patient care. Ideally, a surgeon and physician should be in the same room seeing the patient. Ideally, we should be morphing into a transdisciplinary team process. We should collect ideas, we should fight, share, but before we see the patient, and then we can see the patient, and then we can fight, and after we see the patient, and then we can make a decision. Because sometimes we may not be in agreement in a collaborative approach, but that's good, but we have to discuss it mutually. And I also feel that seamless patient care is important. Once we see the patient, if they do go for surgery, we see them afterwards. It's a follow-up, which is essential. So what is the evidence for patient-centered collaborative care in spasticity management? There's been some opinion papers and discussion papers by Brashear and Eskenazi showing that spasticity management requires a team approach. Doing it solo does not work. Multidisciplinary is important. Again, as I said, sometimes the research has been mixed up because multidisciplinary may have actually meant interdisciplinary. And Demetrios did a Cochrane review, and she did it in 2014. She found 3 studies with 91 patients, and all of them were outpatient appointments for CMT, so constraint movement therapy, and then it was for FES for the other one, and then dynamic splinting. And unfortunately, these were low-level studies that did not really show us about the multidisciplinary or interdisciplinary team, but maybe only one modality of treatment. So there's more research needed in this area of teams. Does an interdisciplinary team or transdisciplinary team make a difference? I would argue yes, but we need more evidence. The Royal College of Physicians, the British Society of Rehabilitation in the UK, had recommendations that we cannot work in solo. We have to manage the spastic patient with a team, and that was a level C opinion paper. So there are studies lacking regarding which type of clinic setup provides the best level of care. studies lacking how to best set up an efficient physiatry, surgical, collaborative spasticity clinic. So I want to now talk about some clinic design models that we have been involved with in British Columbia. But first, I want to show you the demographic picture in Canada. As of yesterday, we have 16 clinics in Canada. And out of the 16, 15 are hospital-based, and one clinic, the one that I had shown you yesterday, the New Westminster Clinic, is a private clinic that does have government funding and that they pay us, and the patient does not pay to be seen, but it is completely solo without any affiliation with the hospital. The other thing with the Canadian spasticity clinics, we have two interactions with surgeons. One is more of a multidisciplinary with a neurosurgeon for the baclofen and pump clinics, and more is the interdisciplinary between the orthopedic surgeon and the physiatrist within the clinic setup. So I would like to do three case studies. One is the non-hospital-based community private outpatient clinic. The second is a novel idea that we're doing at Children's Hospital, trying to transition the child to adulthood. And how do we do that with a collaborative approach? And number three, an early spasticity intervention response team that we have started to design at Royal Columbian Hospital. So let me start with our first case. This is our office building in New Westminster. So why did it happen that we designed a private solo clinic? Well, the reason is because funding ran out from the government to give us a hospital setup clinic in Royal Columbian Hospital. They promised it to us in 2011, and when we were ready to activate the clinic, there was no funding. So we were left with a mess that we had a long list of patients to be seen without a supported clinic. So what we designed as a team, we said, let's take a risk, let's try to do it in our private practice. Now you have to understand, in our private practice, we're seeing knees, shoulders, myofascial pain, spinal cord injury. So how could we actually put a population of such need in a busy setup? So what we did a pilot design for 2 years, and we found that we have to put these patients on one day. So we did 1 day a month starting in 2012 to have a multidisciplinary team. And we started off with an occupational therapist, physiotherapist, and nurse, but then we found that it was too prohibitively costly. We had to find which disciplines would be the most essential. And we found through our design that the nurse or nurse practitioner is worth the money because we have to pay for the nurse and they can do multimodal tasks such as taking the history, positioning the patient. And we also had the model of having two physiatrists at the same time so the physiatrists could cross-share and talk to each other. And we also introduced the orthopedic surgeon, Tom Getz, who's there, and also my friend, colleague, Paul Winston is sitting by George Jacinto, is also part of our clinic. So we also felt that let us try to design the best clinic ever. So we had a recipe that we felt could work. So this is kind of our recipe. No issues of territoriality. We wanted to choose the right people. We wanted adequate time to properly assess patients' medical condition and to set up functional, active or passive, and non-functional passive goals using the GAS. We wanted adequate space and efficient flow. And we have been evolving and morphing to space. I always say, bigger the better, because you will use a space, and that's what we found in our clinic setup. We want efficient access to patient medical records, one record for everyone, and efficient ability for documentation. We also wanted data collection for future research, and we also looked at remuneration. How can we sustain this clinic for a long time? So we have to show the government health economic models, and that's one of the reasons that we want to design this clinic, to show that it's not only my clinics, all of our clinics, if funding runs out, we have to show the governments how we can actually keep this design. Now I've got to say, we are not perfect, we're still evolving. And every time, every week, we're trying to better ourselves. So our team members comprise of 4 physiatrists, 1 orthopedic surgeon. We just recently had a neurosurgeon join our practice, 2 nurses, orthotists, and 2 medical office assistants. We have a concept of a one-stop treatment. We want to do as much as we can within that time constraint with the patient. We have ideally set up the clinic as much as we can with high-low beds, so we have access to all types of patients with care homes and also with increased disability. We have ergonomic assessments of our TV screens and ultrasound scans. We have multiple rooms, 4 rooms, so that we can have efficient flow, and I'll show you how we do that. And we do guided injections for most of our upper limb injections. We also use EMG and nerve stim for localization, lower limb with ultrasound. We also want a concept that no patient should be waiting in a waiting room. They should be in a room so that it looks like a boutique hotel. People feel wanted. They're not just sitting there waiting for the treatment. We have to treat them with decency and respect. We also did not want to have a long follow-up. We want to get these patients in within 1 to 2 months after botulinum injection, because there are many interventions of adjunctive therapy that we should be thinking about. So how do we do an efficient flow in this clinic? We have 4 rooms running at the same time, 2 physiatrists in 2 rooms and 2 backup rooms if we fall behind. The nurses help out with filling out forms and also documentation. They also reconstitute our botulinum toxin. They do ergonomic setup of the ultrasound, so it's like an OR room. So by the time I walk in, I know what's set up and I know how I'm going to approach the patient. The other thing is that we have an orthotic lab and on-site gait assessment. So here's our gait assessment lab. We have the 2 rooms. So we have room number A on the left, room number B on the right. And the corridor, you can see deep down, we have room number 3 and 4. And we have wide offices and hallways and doorways, so we can take patients with stretchers as well. We are set up for procedures, meaning that I will take a picture, so my nurse will take a picture of this patient and we'll log it, and that's what we're trying to do with all our physiatrists, so that next time he comes in, he will be positioned in the same position, so we don't waste time. Because even that 5 minutes of setup time can be very essential for patient care. The other thing that we do, again, is patient positioning. Here's a lady with multiple sclerosis in a very adducted position, rotated pelvic tilt, and she's from a care home. Now, it took us, when we were doing this solo, I could not inject her in a bed. I had to inject her in a chair, and that's not appropriate. So we now have a lift, we have a nurse that can do the setup, but we would book her earlier so she can be set up in the extra room, that by the time I come in, everything is positioned. That saves me time. We also have an orthotic lab within the clinic, so we can actually do casting after toxin or pre-toxin, and this can allow for efficiency. We also are now part of the Canadian Spasticity Database, which is a Canada-wide database for spasticity research, and our clinic is a test clinic, along with Dr. Paul Winston's clinic and GF Strong. And the whole concept is that we do not want to lose data. So the minute the patient comes in, the gas will become standardized on the form. If we're doing nerve blocks, we'll put down how much we're going to inject and also follow that up with time. This will allow us for future ability to do health economic models to prove to the government that we need sustainability and we should be sustained. I want to move on just for the last few minutes, the novel transition to adulthood spasticity clinic collaborative approach. So what is happening in Canada, by age 18, in fact 16, the surgeons are now referring them to us and saying, it's up to you to deal with their care. They've had all the rhizotomies, they've had the tendon lengthening, and now they come to the physiatrist without any documentation, and they come with their family, and the family cannot believe that we don't have the setup of a children's hospital. So what we've planned to do, and we've designed it with one of our colleagues, Kishore Malpuri, who's the head of Children's Hospital Cerebral Palsy Clinic, is that he will now come to our clinic at every 3 months. The patients that he was sending to us before, they will come on the same day. So if it's 6 patients for the morning, then he can introduce these patients to us. And then our team can be introduced to them. And we also now have a link for an adult orthopedic surgeon who will join us on that same day. So this will be a very nice collaborative approach to welcome the patient in the clinic and then to provide more transdisciplinary care with time. And the last model that I want to talk to you is a very interesting one. We've seen Tony speaking about early development of contracture, and that is absolutely true. And we look at George Vissel and colleagues that, by 6 weeks we're starting to have spasticity in many of our patients, but by 6 months contracture has developed. So our idea at Royal Columbian Hospital was to do a novel team. So if you have a stroke, we have a stroke hot team. Why not have a spasticity hot team? So what we've designed is a team that is almost on call. We have a physiatrist, surgeon, nurse, OT, and PT. They are deployed with a difficult case. So once a week, we will spend time on a Friday morning, 1 to 2 hours, where this team can be on call. And this way, we can actually target patients who are developing very increased spasticity, especially anoxic brain injury patient. We can then think about contracture management, tenotomies, and also future direction for baclofen pump. So I want to conclude that I hope that I described the importance of a patient-centered collaborative care. It is mandatory that we do it this way. I would also urge us to think collectively that I know it's not sexy research, but I do believe health economics especially is very important in changing times with funding. We also should be looking at practical strategies to minimize the territoriality between our colleagues. And I think we all have novel models. There's no perfect clinic. So I want to collaborate with you, and I wish you can also come to Vancouver. Thank you.